Welcome back, guys. Now, after discussing about the basics, now let's see the clinical scenarios. First, let's start with the topic of damage to pituitary stalk. Okay. Now, we all know here is the hypothalamus. Okay, this is the hypothalamus. Now, hypothalamus is in contact with it's in connection with the pituitary gland. With the help of this pituitary stalk. Okay, infundibulum pituitary stalk is there. Now, see, this is the connection. Here in this condition, the connection got damaged. Okay, now the pituitary stalk got damaged, so that the pituitary gland is no longer connection with the hypothalamus. Now, what will happen? See, we all know that hypothalamus is the master regulator. Okay, hypothalamus is the master regulator of the endocrine activity. Hypothalamus, it will control the pituitary gland. It will control the anterior pituitary by producing the releasing hormones like growth hormone releasing hormone, gonadotropic releasing hormone, thyrotropin releasing hormone, corticotropic releasing hormone. Okay, now the patient is having maybe an accident, road traffic accident. Because of that, now the hypothalamus got separated from the pituitary gland. Now what happens in this condition? See, the hypothalamic control over the pituitary gland is lost. So now what happened to the growth hormone? Levels comes down. See, growth hormone level is coming down. What happened to thyroid stimulating hormone from the anterior pituitary? See, from top, TRH is not coming, right? See, TRH is getting produced here, no doubt. But the TRH is not coming down because the stalk got damaged. Okay, so the TRH is not coming down, so that thyrotropes are not producing the TSH. Now, what happened to the FSH, LH levels? The gonadotropins, okay, these FSH and LH, their level also goes down. Why? Because from the top, gonadotropin releasing hormone is not coming. Okay, the gonadotropin releasing hormone from the hypothalamus is not reaching the pituitary gland. So that FSH levels, LH levels goes down. And the CRH, corticotropin releasing hormone from the hypothalamus is not reaching to the anterior pituitary. So no CRH, so no ACTH. So all these hormone levels are going down. But please appreciate, from the hypothalamus, the inhibitory hormone is also not coming down. The major inhibitory hormone. What is that major inhibitory hormone? It's a prolactin inhibitory hormone or dopamine. Now the dopamine from the hypothalamus, now it is not coming. It is not coming into the anterior pituitary. Now what happened to the lactotropes? The lactotropes which are inhibited till now. Now these lactotropes which are inhibited so far, now they are activated. Why? Because no inhibition from the higher centers, no prolactin inhibitory hormone, no dopamine. Now what happens? Now it will start to produce the prolactin. Now these cells are starting to produce the prolactin. Now what happens? Now this prolactin, it will cause milk production in a female. Okay, now who is not yet pregnant. Okay, now in 20 years old, by 15 years old, now she start to produce the milk. That is called as a Galactorrhea. So prolactin is going to be increased. But what happened to all the other hormone levels? All these other hormone levels are going to go down. Okay, her growth hormone levels are going down. That will cause severe hypoglycemia. Okay, growth hormone is very important hormone in maintaining the blood sugar levels. Now if growth hormone is going down, means he or she, okay, may end up in hypoglycemias. Thyroid stimulating hormone is going down. Thyroid stimulating hormone is going down means no T3, no T4. Okay, she might develop hypothyroidism. Okay, she might go into the hypothyroidism. See, FSH, LH are going down. What happened to the FSH, LH goes down? Automatically no follicular stimulation. Okay, no follicular stimulation. So no development of the follicles, no estrogen levels. Her estrogen levels goes down. Okay, she might suffer with amenorrhea. Okay, menstrual irregularities, and ACTH levels are going down. ACTH is very important hormone for the production of cortisol. Now in this condition, what happens? Cortisol level is going down. When cortisol is not there, what happened to the BP? Cortisol is a very important hormone in the maintenance of the tone of the blood vessels. If cortisol is going down, the person might end up in hypotension. So what I am trying to put in your mind is the clinical case will come something like this. Okay, the patient is having a road traffic accident because of which this patient who had a road traffic accident have gone through the MRI. In the MRI, it was shown that the pituitary stalk got damaged. Now what are the probable complications that he or she might encounter in the future? Okay, he or she might go into hypothyroidism, menstrual irregularities, okay, the hypotension or hypoglycemia, and Galactorrhea. Galactorrhea can be seen. Why Galactorrhea? Because of increased prolactin, because of the increased prolactin. And also remember, this increased prolactin inhibits, okay, prolactin, what it will do? Prolactin inhibits GnRH. Okay, prolactin inhibits the GnRH. GnRH will be like going down. Simply I am just trying to put into your mind that, see, this prolactin, what it will do, it will decrease the GnRH. In later lectures you will understand what is this importance. Prolactin, whenever you have prolactin inhibits the GnRH and it decreases the FSH levels, LH levels. But in our condition already FSH, LH are going down in our condition. Okay, usual physiology, I am talking about the normal physiology. In normal physiology also the prolactin decreases. Okay, prolactin decreases the GnRH levels. Okay, so in a pituitary stalk damage, all the hormone levels are going to be decreased except prolactin. Okay, now next, let's talk about a syndrome called as the Sheehan syndrome. Sir, what exactly is Sheehan syndrome if you ask me? Please see here. Okay, here you can clearly see the pituitary gland undergone the necrosis, infarction, the pituitary gland gone infarction. Why? Why? See, this Sheehan syndrome, let's try to understand like this. Imagine that there was this one female, okay, now she is in term, okay, now she is having 38 weeks. Okay, now she is going through the vaginal delivery, normal vaginal delivery. Now C-section doesn't matter, now she is going through the normal vaginal delivery. Now after delivery, okay, there should be proper clamping down of the blood vessels. Okay, all the bleeding blood vessels need to be clamped down. Okay, normally after delivery. Okay, baby delivered in the second stage of labor. In the third stage of labor, the placenta is delivered. Once the placenta is delivered, means normal the uterus have to undergo contractions. Now these contractions are very much important because these contractions will actually clamp down the bleeding blood vessels. Okay, all the blood vessels which are bleeding, now those blood vessels need to be clamped down. Otherwise what happens? Continuous bleeding will lead to postpartum hemorrhage. She will go into the shock. Okay, she will go into the shock. So what I am trying to put in your mind is, see, this female is there. Now she is having 38 weeks of period of gestation. The period of gestation is 38 weeks. Okay, now she is going through the labor, normal vaginal delivery. Now baby was delivered. Now she is going into excessive hemorrhage. How much hemorrhage? For example, if I am talking normal vaginal delivery, right? Now here in this condition, more than 500 ml blood loss. Okay, if it is C-section, I should say more than 1000 ml blood loss, but no one is going to actually follow this thing. Usually nowadays we say that more than 1000 ml blood loss is called as postpartum hemorrhage. Postpartum hemorrhage. Now this female, okay, now this female is losing lot of blood. That's what I mean by postpartum, after delivery hemorrhage. Okay, postpartum hemorrhage. Now she is losing lot of blood. Now tell me, if a person loses lot of blood, there will be hypovolemia. Okay, usually BP will be falling down. In order to maintain the BP, okay, in order to maintain the BP, when the blood is when the person is losing the blood, what happened to the blood vessels? To prevent the blood loss, to maintain the BP, the blood vessels will undergo vasoconstriction like this. So now same thing will happen in this female also. Okay, now in this female, what happens is blood vessels will undergo vasospasm. Okay, now this female is having vasospasm. Okay, this is one half of the story. Let me tell you what exactly happened during pregnancy. During pregnancy, what happened is, in order to maintain the metabolic demands, okay, now she is not just one person, okay, she is actually two persons. Baby is also there, right? So during pregnancy, what happened to her pituitary gland? Something special happens to her pituitary gland. In order to maintain the demand, her pituitary gland will undergo hypertrophy. Okay, the pituitary gland will undergo hypertrophy. From small size to it will undergo hypertrophy. Actually, there is 136% decrease in the size of the pituitary gland during pregnancy. Okay, this is also an MCQ. 100% means double in size. 100% decrease means double. Okay, 136% means the pituitary gland size. Okay, here please try to understand. The pituitary gland size becomes more than doubles. Now, more tissue means it demands more oxygen. So, in a female who is pregnant, now her pituitary gland is bigger and it demands more blood, it demands more oxygen. Okay. Now, in this female, what is happening? Yes, she is pregnant, she delivered a baby. Now, after delivery, she is having a complication and that complication is postpartum hemorrhage. Now, what happens? So, there is vasospasm. So, now my question to you, what happened to the blood supply to the pituitary gland? Now, is it receiving more blood or less blood? See, already pituitary gland is hypertrophied. It's such a big pituitary gland. Now, it is demanding more blood, but instead of demanding more blood, now what is the amount of blood supply to the pituitary gland? In her body, all the vessels, they got vasospasm. So, little to less blood is going to the pituitary gland. Now, what will happen? Now, the pituitary gland is developing hypoxia. Okay. Now, hypoxia in worst case scenarios will turn into infarction. The pituitary gland might undergo necrosis. So, this is what exactly happens in the Sheehan syndrome. So, what is Sheehan syndrome? Sheehan syndrome is postpartum okay, postpartum necrosis of pituitary gland. Okay, it's a postpartum necrosis of the pituitary gland. So, postpartum, after delivery, in some females who is having a complication of postpartum hemorrhage, so those females, there will be vasospasm, and that vasospasm will cause hypoxia in the pituitary gland. So, the pituitary gland will undergo infarction. Now, tell me what happens in this Sheehan syndrome. The entire pituitary gland, anterior pituitary gland, posterior pituitary gland, entire pituitary gland got infarcted, or entire necrosis happened. So, what happened to the somatotropes? Somatotropes are dead, lactotropes are dead, thyrotropes are dead, corticotropes are dead, okay, and gonadotropes are dead. All the cells in the anterior pituitary got dead. So, what happened to all these hormones? Growth hormone is going down, TSH going down, FSH goes down, LH goes down, ACTH goes down, even prolactin goes down. So, that is why these females, they had a complication of hypoglycemia, they had a complication of hypothyroidism, menstrual irregularities, hypotension, and even they won't even have proper breastfeeding. Why? Why? Because see, prolactin is not there. There is no prolactin. See, this female, she have delivered a baby, right? The baby need to have the milk. Now, because of prolactin deficiency, even milk production is not there. So, these are some important complications which are seen in Sheehan's syndrome. Okay, postpartum necrosis of pituitary gland is Sheehan syndrome. Now, after this, let us discuss about one more condition, one more clinical case. In order to understand that, let us try to draw a small diagram. See, this is the hypothalamus. Okay, this is the hypothalamus, and here I am showing you the pituitary gland. Okay, just only anterior pituitary. Okay, anterior pituitary. Now, hypothalamus, it produces, see, this is a hypothalamic nuclei. This hypothalamic nuclei is producing gonadotropin GnRH, gonadotropin releasing hormone. Now, this gonadotropin releasing hormone, see, it is coming to the anterior pituitary, and in the anterior pituitary, which cells are there? Now, in the anterior pituitary, gonadotropes are there. Okay, gonadotropes are there. Now, when this GnRH, when it comes and acts on the gonadotropes, we all know the gonadotropes are going to produce FSH, okay, gonadotropins FSH and LH. Okay, FSH helps in follicular development, LH helps in ovulation. LH, luteinizing hormone, helps in ovulation. We all know that. The point is, now this GnRH is coming from the hypothalamus in pulsatile doses. If this GnRH is coming and acting on this gonadotropes in pulsatile doses, yes, these gonadotropes will be activated, and it will produce FSH and LH, gonadotropins are produced. But if this GnRH is coming from the hypothalamus continuously because of some reason, now if GnRH is continuously stimulating the gonadotropes means what happens? Now these gonadotropes are inhibited. Now what happens is FSH levels goes down, LH levels goes down. Okay, now these gonadotropins will go down. So, 2 points. If the gonadotropin releasing hormone, if it is released in pulsatile doses means regular intervals, not in a continuous form, in a regular, little by little. Now, in that condition, gonadotropes are activated. Now, the gonadotropes, they will produce FSH, LH. Otherwise, if you have continuous release of gonadotropin releasing hormone, continuous stimulation of these gonadotropes by gonadotropin releasing hormone, then these gonadotropes are inhibited, or I should say the gonadotropin receptors, okay, gonadotropin releasing hormone receptors, those receptors are desensitized totally. Okay, now what happens? Now this gonadotrope is inhibited and FSH goes down, LH goes down. Sir, how to use this understanding in treatment of certain disorders? For example, see, continuous GnRH, I have explained to you. Continuous GnRH, gonadotropin releasing hormone, it suppresses the gonadotropin release. True. Continuous stimulation is not good. Not good. Okay. So, we have manufactured certain drugs in the pharmacy. Okay. In the pharmaceutical industries, we have made certain drugs which are analogues of GnRH. So, GnRH-like drugs. What are these GnRH-like drugs? Leuprolide, nafrelin, goserelin, buserelin. Okay, all these drugs which are ending with relin drugs. Okay, so leuprolide, nafrelin, goserelin, buserelin, like this, many drugs are there. So these are nothing but, okay, these are nothing but GnRH. Now you can use these drugs. Okay, you can use these drugs in pulsatile doses for treatment of certain disorders, or you can use these drugs in a continuous doses for the treatment of certain disorders. For example, say, when you will use these drugs in pulsatile doses, leuprolide, goserelin. See, in the conditions of delayed puberty, okay, in the conditions of delayed puberty, you have to use this gonadotropin releasing hormone analogues in a pulsatile dose. See, pulsatile dose means little by little, regular intervals that will activate the gonadotropes. Okay, we are activating the pathway, we are activating the axis. In which conditions? In delayed puberty. My question to you, what is delayed puberty? Puberty is delayed. Imagine that there is this one girl who is 18 years old or 16 years old. Now she is not having her menses. Okay, 18-year-old girl not having a menses is not a normal thing. No, her puberty is delayed. Now she was normally supposed to have her menses by 13 years or 14 years. Okay, breast development and puberty have to happen by 14 years. But now she is 18 years and still she is not having the menses. Menarche is not attained. So definitely she is having delayed puberty. So now in her body, you need to activate the axis or you need to inhibit the axis. You need to activate hypothalamo-pituitary gonadal axis. So once you activate, gonadotropins are produced, FSH is produced, LH is produced. What FSH will do? It stimulates the follicles to grow. Now her follicles in the ovaries will be stimulated, estrogen will be produced. With that estrogen, she will be having breast development. Once the follicles are matured, follicles will give positive feedback for the release of LH. LH will cause ovulation. Now she will have her menses. Okay, she will have her menses. So in a female who is having delayed puberty, female or male, okay, whoever are having this delayed puberty, you need to activate the hypothalamo-pituitary gonadal axis. For that purpose, you need to use these analog drugs in pulsatile doses. Okay, and not only that, in Turner female. What exactly is Turner female? Turner female is 45x0, 45x0, 0 means one X chromosome. One X chromosome is lost. Now this is a female. Okay, Turner female. Now this Turner females, what's the problem? Her ovaries are very streaky ovaries. Thin sliver of ovarian tissue is there. Okay. Now in her body, estrogens are not there. Okay, in her body, estrogens are not there. Now, estrogens are not there means what is her problem? Her problem is not just the breast development. Okay, it's not just the breast development. Whenever estrogens are not there, the osteoclasts are activated and those osteoclasts, they will cause bone resorption. And that bone resorption at the end of the day will lead to easy fractures in this female. So, Turner females are at a risk of easy fractures. Okay, easy fractures. So, in order to prevent those fractures, in order to just stop the bone resorption, what you can do is by activating this pathway, hypothalamo-pituitary ovarian axis, so you are actually activating the thin salivary ovaries. So what will happen? A little amount of estrogens will be produced. Even that little amount of estrogens will help her to prevent the bone resorption. Okay. So in a Turner female, estrogens are not there. Remember, in Turner female, estrogens are not there. Estrogens are not there means bone resorption will happen. So what you need to do? You need to give these drugs in pulsatile doses. When you give these drugs in a pulsatile doses, what happens? Her pituitary gland will start to produce FSH-LH. This FSH will stimulate the ovaries to release the estrogen, and that estrogens are osteoprotective. That's what I am trying to put it to your mind. Okay. Now after this, let's talk about the usage of these drugs. Okay, gonadotropin releasing hormone analogs in a continuous form. Okay, in a continuous form. Now in which conditions we have to use these drugs in a continuous form? Like exactly opposite thing, precocious puberty. Now what exactly is precocious puberty? Precocious puberty means, imagine that there is this one 8-year-old girl. Okay, 8-year-old girl. Now in this girl, menses have started. Okay, now she have the menses, menarche is attained, or the breast development. Now she is developing her breast and puberty is there. Now do you expect a 8-year girl to bleed? Definitely not. Okay, that's not the time to go through all this process. So what we have to do? We have to inhibit the axis. Okay, we have to inhibit her gonads. Okay, this is not the time for the follicular development. Okay, she is such a small girl, right? So what you need to do? You have to give the same drugs. Okay, you have to give the same drugs in a continuous form. When you give these drugs in a continuous form, her ovaries are inhibited. Hypothalamo-pituitary ovarian axis is inhibited. So no FSH, no LH. No FSH means no follicular development. No follicular development means no estrogens. No estrogens means no breast development. No endometrial proliferation. No menses. Simple. In a simple way. Okay. So if there is precocious puberty means you have to use this analogs in continuous form. Okay, well and good. And also, these drugs are used in the treatment of certain important disorders like endometriosis, breast cancer as well as the prostate cancer. Simple. What exactly is endometriosis? Okay, endometriosis. Endometrium is a tissue which was supposed to be present inside the uterus. Okay, see here is the uterus with the cervix. Now endometrium, where it should be present? So endometrium was supposed to be present. See, endometrium is supposed to be present within the uterus. Okay. Now if endometrium grows outside the uterus, maybe in the ovaries, the most common site of endometriosis. Okay, the most common site of endometriosis is ovaries or the pouch of Douglas. Okay, the second most common site, or somewhere. Okay, on the peritoneal cavity, or even it can, endometriosis can happen even in the brain also. Even the endometrium can go into the brain and can grow in the brain, it can go in the orbits, it can grow in the the nasal mucosa, it can go anywhere in the body, So growth of the endometrial tissue is called as endometriosis, simple. Now in endometriosis, what is exactly the problem? Simple, endometrium, ectopic, ectopic endometrium is growing. Now if I ask you, who is the stimulant, who is the food, who is the food for the endometrium? The food for the endometrium is nothing but the estrogens. Food in the sense stimulus. So what is the stimulus for the growth of endometrium? Estrogens. Now what you need to do in the condition of endometriosis? In endometriosis, we don't want endometrium to grow. We want to atrophy the endometrium. If you want to atrophy the endometrium, what you need to do? You need to decrease the estrogens. If you want to decrease the estrogens, you have to stimulate the ovaries or you have to inhibit the ovaries. You have to inhibit the ovaries. How you can inhibit the ovaries? By giving GnRH analogs continuously. If you give the GnRH analogs continuously, the anterior pituitary is inhibited, gonadotropes are inhibited, no FSH, no LH. No FSH means no follicle stimulation, no estrogen. No estrogen means automatically the endometrium will undergo atrophic changes. So all the ectopic endometrium, wherever it is there, it will start to undergo atrophy. So these are the points about the endometriosis. Even breast cancer. What is the breast cancer? Breast cancer is it's a cancer in the breast. It's simple way. It's a cancer in the breast. Now, what is the food for this breast cancer, or what is the stimulus for this breast cancer? It's the estrogen. Estrogen helps in breast development. We all know this thing. For estrogen cancer also, or this breast cancer also, estrogen is the stimulus. So what you need to do in the breast cancer patient? You need to decrease. You have to actually decrease the estrogen levels. When estrogen levels goes down, actually the tumor size decreases. Because no stimulation is there, right? So automatically the tumor size decreases and it will be very easy for the operation to perform. Even breast cancer, same stuff. In prostatic cancer also. In prostatic cancer in males, it is the dihydrotestosterone which is the stimulus. You have to decrease what? You have to decrease the amount of the sex hormones. If you want to decrease the sex hormones, you have to inhibit the gonads. If you want to inhibit the gonads, you have to use the GnRH analogs in a continuous form. You have to use the GnRH analogs in a continuous form. So the concept is, yes, where we have to use the GnRH analogs in a pulsatile doses and where we have to use the GnRH analogs in a pulsatile doses as well as the continuous doses. So these points which I want you to know. After this, let's discuss about one more clinical case, that is Prolactinomas. So what exactly are these Prolactinomas? See, Prolactinomas are the tumors of lactotropes. They are the tumors of lactotropes. Normally lactotropes are supposed to produce what? Prolactin. We know lactotropes are one of the acidophilic cells in the anterior pituitary. So what are these Prolactinomas? They are the tumors of lactotropes, and these Prolactinomas are the most common anterior pituitary tumors. They are the most common anterior pituitary tumors. Now, whenever you have this Prolactinoma, pituitary gland is going to become big in size. Not only Prolactinomas, guys. Here I am taking Prolactinomas because Prolactinomas are the most common tumors of anterior pituitary. Not just Prolactinomas, any pituitary adenoma, any pituitary tumor. What will happen? Pituitary gland size will be increased. When you increase the pituitary gland size, see, this is the pituitary gland. When you increase the pituitary gland size, what happens? Now this pituitary gland, it is going to grow bigger, and now it will start to compress the surrounding structures. The most important surrounding structure is the optic chiasm. Here is the optic chiasm. Now that optic chiasm is now getting compressed. Later, watch the CNS video. There I have explained clearly that in this optic chiasm, what happens? The nasal retinal fibers. The nasal retinal fibers, this is the nasal retina, this is the nasal retina, this is the temporal retina, this is the nasal retina, here is the temporal, this is the temporal retina. Important point is, the nasal retina is looking at the temporal visual field, nasal retina, it looks at the temporal visual field, nasal retina is getting the information from the, or I should say the nasal retina is getting the light information from the temporal visual field, and the temporal retina is looking at the nasal visual field. Now what is happening? See, this nasal retinal fibers, important point is the nasal retinal fibers, they will cross in the optic chiasm. In the optic chiasm, which fibers are crossing? The nasal retinal fibers are crossing. If this nasal retinal fibers are crossing, means now say, in the Prolactinomas, now optic chiasm is getting compressed. If optic chiasm is getting compressed, which fibers are damaged? It's the nasal retinal fibers are damaged. If nasal retinal fibers are damaged, means which vision is lost? It's the temporal vision is lost. So now this patient is going to lose the temporal vision. The nasal vision or the central vision. The central vision, it's okay, he can only see in the center. But this temporal vision is lost because optic chiasm is damaged. If optic chiasm is damaged, the nasal radial fibers are damaged. Okay, why the optic chiasm is getting damaged? It's getting compressed from the pituitary tumor. What are the most common pituitary tumor? The most common pituitary tumors are prolactinomas. Okay, sir, very good. So, one visual loss is there. This is called as a bitemporal hemianopia. Okay, so bitemporal hemianopia or anopsia is all the same thing. Okay, different books are mentioning the different names. Bitemporal hemianopia. This is the loss of the bitemporal vision because of the compression of the optic chiasm. Now, apart from this, what else clinical features will be there? See, these females, if this happens in a female, now she is going to have amenorrhea. Okay, why she is going to have amenorrhea? Because it's a prolactinoma. Okay, prolactin producing tumor of the lactotropes. Now, what this prolactin is going to do, already I have discussed with you, the prolactin, it will actually inhibit GnRH, gonadotropin releasing hormones. Now, in her body, the gonadotropin releasing hormones are going to go down. Whenever the gonadotropin releasing hormones goes down, what happened to FSH, LH? FSH goes down. What happened to LH? LH goes down. See, if there is no FSH means no follicular development. If there is no LH means no ovulation. So, that's why she is having amenorrhea, no ovulation and no menstruation. Okay, whenever there is no follicular development and no ovulation, automatically she will go into the amenorrhea. And not only that, now she is having what? Now she is having excessive amount of prolactin. Because of the prolactinoma, she is having excessive amount of prolactin. What is prolactin will do? Prolactin will go to the breast and will stimulate the milk production. Okay, milk production that causes the galactorrhea. Now, let's talk about the gynecomastia. So, what exactly is this gynecomastia? Especially if this happens, if these prolactinomas are coming in a male, it will cause development of the breast tissue. Okay, the prolactin will cause the development of the breast tissue. High levels of prolactin will cause the development of the breast tissue in a male, that is called as a gynecomastia. Okay, now how to treat such conditions? Okay, you can treat these conditions by using certain drugs. Okay, symptomatic treatment, actually you need to, it's a space occupying lesion, right? It's a space occupying lesion in the brain. Actually you need to do the surgeries, but anyway, symptomatic treatment, you can decrease the symptoms by giving prolactin antagonist. Okay, drugs decreasing the prolactin. See, this Galactorrhea is caused by prolactin, this amenorrhea is caused by prolactin, this gynecomastia is caused by prolactin. So, symptomatic treatment is by decreasing the prolactin. How can you decrease the prolactin? In the basics we have studied, prolactin inhibitory hormone. Prolactin inhibitory hormone is nothing but the dopamine. So, in this condition we have to use dopamine or dopamine-like drugs or dopamine receptor stimulants. So, what are these drugs? They are cabergoline, which is a drug of choice. Go for the symptomatic treatment of the prolactinoma. So, cabergoline, okay, nothing but the dopamine receptor agonist, and bromocriptine, dopamine receptor agonist, L-dopa, nothing but levodopa, okay, dopamine, nothing but a dopamine, or dopamine you can use. So, these are the drugs which will decrease the prolactin levels in a patient who is having prolactinomas. Okay, so with this we are done with the 4 important clinical cases, okay, which are related to the pituitary gland. Now, after this, in the next video, let's start with the topic of posterior pituitary and the hormones from the posterior pituitary. Hope the video is helpful. Thank you.